Women-centered care, developing a framework for addressing FEMA-only requests on labor and delivery. Patients request FEMA-only care on labor and delivery for a number of reasons, challenging clinicians in their ability to safely and sensitively care for women from different backgrounds. Preference for gender concordant care among Muslim women has been studied and documented in the literature, and some studies have reported delayed healthcare seeking behaviors due to these preferences. Despite these concerns, there are currently no clear guidelines on how to address these requests at our institution, and there is a scarcity of literature on this topic. This gap in the literature, alongside with our experiences, led us to perform a quality improvement project in order to evaluate clinician experiences and patient experiences related to FEMA-only requests. We interviewed 15 Muslim women who delivered at our institution within the past 2 years and surveyed 15 family medicine physicians who work on labor and delivery. We then performed a thematic analysis in order to develop recommended guidelines to provide safer, patient-centered care. We identified 4 major themes from patient interviews and 4 themes from clinician surveys. In terms of the basis of preferences, interviews revealed women had varying reasons for preferring FEMA-only care, including culture, religion, in particular Islam, as well as feelings of shyness and embarrassment by virtue of undergoing more sensitive exams. In terms of prenatal discussions, there was a lot of variability as to whether discussions even occurred in the prenatal setting, as well as the scope of conversation if it did occur. In terms of comfort level with male care, there was a wide range. Notable was that preferences were often expressed for both physical exams and verbal communications, and emergency situations were often exceptions to preferences. Factors that made care more comfortable included having a female staff member, like a nurse, serve as a mediator between the patient and a male physician in order to limit interactions. Other factors included using blankets to help cover, as well as having a prenatal discussion. Clinician surveys revealed varied practices when addressing requests, including discussing that they cannot guarantee FEMA-only care secondary to call pool and resident attending structure, the potential to transfer care, exploring religious and cultural concerns, and attempting to accommodate when safe. Clinicians noted a variety of barriers to accommodating care, including lack of consistent prenatal conversations and documentation, lack of knowledge in culture and religion, safety concerns, discomfort from family members, disconnect within the care team, and difficulty including male learners. Safety concerns included patients refusing care during an unsafe time, resident supervision issues, as well as risk of error with changing workflows. Lastly, clinicians suggested a number of ways to improve care, including standardizing prenatal conversations and documentation, using a conversation script to facilitate conversations, and engaging in more dialogue with women, as well as community outreach. Based on these themes, we developed recommended guidelines to address requests for FEMA-only care, including standardizing prenatal discussions through the use of educational documents and patient-centered conversation guides, standardizing documentation of preferences so that the care team is aware and can accommodate when safe and possible, standardizing practices around entering rooms, minimizing direct male contact by having female nurses and residents perform exams when safe and reasonable, considering potential female options on labor and delivery like doula care or midwives, and training for both nurses and physicians on cultural and religious sensitivity.